Hi, a very warm welcome to second session of Type 1 Diabetes Education Series. Today we are going to talk about insulin, its theory, and the practical considerations that we need to do while we are asking somebody to inject insulin. So we are on the second session in this 10 module Type 1 Diabetes education course. And this is a brief recap of what we learned in session one. We learned about basics of type 1 diabetes. How is it type 1 diabetes different from type 2 diabetes? What are the symptoms? What are the basic presentations? And why is the need of insulin in type 1 diabetes? And if we are prescribing somebody insulin in type 1 diabetes, we need to take that in a basal bolus manner. So now we know that insulin is a life-saving drug for anybody who's got type 1 diabetes. And the best way to give them insulin for type 1 diabetes would be to emulate same normal physiology by which insulin is secreted in any human body, which means that one basal insulin and then another mealtime insulin doses that we need to give before each meal. In today's session, we are going to discuss as to how do we start titrating the dose. Somebody's got type 1 diabetes, and then what are the steps, the practical steps in which we think that this is how the therapy or the dose should be started? What are the factors that need to be considered into that? And then practical parts of how to inject, where to procure, how to store, and all practical aspects related to the insulin use that we're going to use in the end of the session. So just to recap, there is a glucose which is present in the food in form of carbohydrates by way of digestion. This is broken down into simpler carbs into our gut, and then that glucose is absorbed into blood, becomes blood glucose, and then some of this blood glucose goes to pancreas, makes it secrete more insulin, and then this insulin comes and act as a key to the entry of glucose into muscle cells. It opens a channel, and we are going to see that in the coming slides in a grammatical or the more animated form as to how that works. Now, a little bit more about pancreas and beta cells. So there is an organ in our body which is called pancreas, which is situated right behind our stomach, and then in tail of that pancreas. So the bigger shape that is there right in the middle of your screen is the entire pancreas, and in the smaller tail portion of that pancreas, we have something called islet of Langerhans, and these islets have got four different cells: alpha, beta, gamma, and somatostatin producing cells. So all these cells produce some form of hormones, but what we are connected with is concerned with today is insulin and another hormone which we call as glucagon. Now you need to think of glucagon as two twin brothers or two siblings, and they act as somebody sitting on a seesaw. So as insulin goes up, glucagon goes down, but as insulin requirement goes down, then glucagon goes up. And that happens because both of them work in a very, very tandem way to keep our blood glucose values into a very, very narrow range. Insulin tries to reduce blood glucose values by pushing that glucose into our muscle cells, into our liver, into our adipose tissue fat cells, while glucagon does the exact opposite. Make liver produce more glucose, make fat cells release more triglycerides into the circulation. So glucagon works in an entirely different way or in the opposite direction as the insulin does. And that, in fact, that's how they are secreted. So the concentration of insulin within that islet of Langerhans cells decides how much glucagon to be produced. So the lower the concentration of insulin, the more glucagon is produced into the blood. And then they exactly work in the opposite direction. So insulin works on muscles, liver, and fat to push glucose inside, while the glucagon increases blood glucose values. And then by working in tandem fashion, they keep blood glucose values in a very, very stable range. Now, another component that we need to understand is that the blood glucose that's there after we've taken food, it goes to the pancreas, and then it goes into the pancreas cells through glucose transporters, which are called GLUT1 and GLUT2, largely GLUT2. But like muscle cells, these transporters are already there on the cell surface. So pancreas secretes insulin in a dose-dependent manner. So whatever glucose is present in the blood, it goes to the pancreas, and then the pancreas secretes insulin to counter that glucose. It will keep on increasing production of insulin as our blood glucose keep on going more, but till the time it hits its production limit. So beyond a certain limit, of course, no cells can produce insulin. So if your sugars goes way beyond that values, then of course the insulin secretion will not get increased. But otherwise, as blood glucose values goes up, the secretion of insulin keeps on increasing. Now, glucose binds to GLUT2, and then result is the secretion of insulin into the blood cells. So that is what these slides want to represent it to you. Now, just to look at as to how this glucose goes into the muscle cell. So I just tried to create animation where if you see, so the cell written on the right side corner of your screen means muscle cells. So the muscle cell has got an insulin receptor on the surface, which it always is there, and this is called GLUT4 receptor, and insulin receptor. And then the glucose receptors are within the cell, within the body of cell. They are not on the surface of the cell. So glucose can only come through the cell membrane or the cell boundary only when these GLUT4 are there on the surface. Now, what this insulin does is, so when insulin comes, it goes down to insulin receptors, it makes these GLUT4 move to the cell surface, and then as GLUT4 moves to the cell surface, the glucose comes into the muscle cell. So that's how this entire thing is limited. We should absolutely be clear about all these things as to how so the glucose goes into pancreas cells without needing anything, because on those pancreas cells, GLUT1 and GLUT2 are already on the cell surface. While in the muscle cells, the GLUT4 are within the cell body, and to bring them to the cell surface, we need insulin receptor to be working in tandem with the insulin molecule that's there. Now the insulin is secreted from the pancreas. Before it is secreted, there is another molecule. So insulin is, if you look at, it's not that the body only makes insulin. So the cells, which beta cells in the islet of Langerhans cells, which produce insulin, they initially make a larger molecule called proinsulin. Then they trim it down to two different molecules. One is called insulin and another is called C-peptide. Now, what happens is this insulin has got a very, very short half-life into the blood. So the job of insulin is it comes out of pancreas, goes to the muscle cells, and then it works. Now, if we want the systems to be very, very adaptive to the blood glucose, change in the blood glucose. So say, for example, my blood glucose is going up from 100 to 200, and then it suddenly comes down back to the 100. So for all these dynamic changes to be working, this insulin should only be working for a very, very small time. And that's what it does. The half-life of insulin is only 3 to 5 minutes. So it makes measurement of insulin to the blood little difficult, because you check now, you check half an hour, you check 2 hours later, your blood insulin values may keep on changing as your blood glucose values changes. While this C-peptide is the second half of the proinsulin molecule, which is secreted, which is also secreted into the blood along with insulin. And as much insulin is secreted, as much C-peptide is secreted. But C-peptide has a longer half-life, does not get cleared from the body as soon. So what we do is we measure C-peptide in the blood as a surrogate marker of insulin production. So in type 1 diabetes, because by nature of definition of type 1 diabetes, we are saying that the production capacity of beta cells to produce insulin is limited, which basically translates to that if your blood has got less than 0.6 ng per ml of C-peptide, then it is indicative of absolute insulin deficiency, right? Please remember units here, because sometimes C-peptide is measured in nanomole. In those units, it would be 0.2, but in ng per ml, it is less than 0.6. So we do one test. If we are confused in somebody, whether the person, how much insulin secretory capacity that person has, then we do a C-peptide test and we come to know that it is. Although the caveat is that if somebody is already taking insulin from outside, then their pancreas may no longer feel the need to produce more insulin because the body already has insulin from outside. And when we take insulin from outside, of course, that insulin is not given along with C-peptide. So your C-peptide can be falsely low in people who are taking external insulin from outside. So if you want to really differentiate somebody between having type 1 diabetes and type 2 diabetes, so ideally their C-peptide should be done before they are being started on insulin, not after they are on insulin. Now, just to tell you that this is basically the structure of insulin. So the insulin which is produced inside our body. So what I have to emphasize here is body produces only one kind of insulin, and this insulin is called regular insulin. This insulin has got two amino acid chains, and they are linked with two disulfide bonds. Now, because if body needs very, very small dose of insulin, as we discussed last time, as a basal insulin, so same insulin is secreted in a very, very small quantities all along. Once we eat meal, concentration of same insulin goes up, and then more amount is increased, and then the function of insulin is done with. Now, what happens when we take this insulin from outside? Now, if we take same insulin from outside, now how does outside insulin work is we inject that insulin into our subcutaneous tissue. Subcutaneous tissue means beneath the skin. Now, once we have injected that insulin there, it is no longer responding to blood glucose values or the food that we are going to take. It just corresponds to, it just keeps on releasing insulin into the blood from that subcutaneous tissue. Now we know that we cannot put in insulin in there and then allow it to just keep on getting secreted at whatever rate it wants. We want to control that. So what we did to control that is we started making modifications in this insulin molecule. So we made some chemical modifications in which one preparation was made in which the release from subcutaneous tissue was delayed. So then those become longer acting insulins. While there were other insulins which were made to release or travel from subcutaneous tissue into the blood very, very fast. So they become faster. So they have a faster dissociation. So the slower dissociation and faster dissociation. So the rate of travel from subcutaneous tissue to blood is increased, and then more and more it is increased, more and more it resembles a basal secretion. The faster it is also dissociated, so the faster is the rise in the blood. So faster dissociating insulins are called rapid insulins, and they are used as pre-meal insulin doses, and the slower dissociation are called longer acting insulin. They act as a basal insulin. Now there are multiple insulins made by different companies which work for both, which make both basal and rapid acting insulin. For example, Novo makes aspart insulin which work as a pre-meal insulin, while it makes Degludec which works as a basal insulin. Similarly, Sanofi makes something called Glulicine or Apidra as a rapid acting insulin, and same company makes insulin Glargine and Glargine 300 IU per ml, which work as a basal insulin. So there are different kind of basal insulin, there are different kind of rapid acting insulin. Rapid acting insulin, practically all of them work in a similar manner. There are newer categories of even ultra fast acting insulins are coming. One of them is called FIASP, or the fast acting aspartate. And in smaller children, it may be useful because it can be given immediately after taking food also. So sometimes in smaller children, we are not sure as to how much food are they going to eat. So we let them eat first, and then if we inject this fast acting insulin, it can give us similar results as the other insulin when they are injected beforehand. Similarly, there are different kind of the basal insulin are there, but the largely that we use are the called glargine or the Tosio, which is again glargine 300 IU per ml, and then a degludec. There is another basal insulin which is called NPH, which again is a very common, used in especially in rural areas and in the government setting. So that NPH is the original basal insulin that was there, but it has to be given twice in a day to act as a truly basal, because it only works for 12 to 16 hours. It does not work all across 24 hours. So these are the different insulin preparations that we ask people to take. So, and these are the different profiles. So the another difference is that the internal insulin is produced from the pancreas into something called portal circulation. Now, the difference between subcutaneous tissue and portal circulation is that insulin goes through the liver. So the pancreas secretes insulin into the blood, but that entire blood goes through the liver. So the liver need larger concentration of insulin to work properly, or to handle glucose properly, I should say. And then, but in the subcutaneous tissue, the liver gets as much as the entire rest of the body gets the insulin. So the response of endogenous insulin, or the insulin which is secreted by pancreas, is much better response to the food that we take. While the rapid acting insulin, then analog premixes, and then short acting, intermediate acting, and longer acting, they have gradually longer action. One thing that I need to point out here is something called premix insulin. So what we do is, in one syringe, we use rapid acting insulin and a long acting insulin. We combine them, hoping that we might have to give them only twice in a day. But that's not the standard of therapy in type 1 diabetes ever, because that we have already discussed in last session, that basal bolus is the way the nature produces insulin in any human's body, and then in type 1 diabetes we should follow the same pattern. So this is what we want: a basal insulin and then a rapid acting insulin given before any carbohydrate containing meal. That may be 3 major meals, or that may be smaller snacks, that it should be there. And then what we want is that our insulin that we take at any meal time should match with the food that we take, right? So if we take same dose of insulin but we take lesser food, then of course your sugar values are going to go low. But otherwise, if you take more food, then your sugar values might go higher, even while you are taking same dose of insulin. So we need to be able to match that insulin dose that we are taking before each meal. And then we are going to discuss as to what are the first steps in which we start matching those doses. So so how do we start it? So basically what we start doing is that first of all, we try and see as to how much total dose of insulin would be required by somebody with type 1 diabetes. Now, most of the time, children would have adequate response on somewhere between 0.8 to 1 unit per kg per day. Anybody who's been diagnosed with type 1 diabetes for a year or more, approximately, although we might have to individualize it, and every person would require at least 0.8 unit per kg per day. Roughly, half of it can be given as the basal therapy, and half of it, divided into different doses, can be given as a pre-meal insulin. There are two terms that we need to be absolutely clear about, because those do make the basics of the insulin therapy in type 1 diabetes. They are something called insulin carb ratio. And we would be discussing about these in this session also, and in more detail in the diet in the coming sessions, specifically about we've got a special session based on them. So something is called insulin carb ratio, which means number of grams of carbohydrate metabolized by 1 unit of insulin. So say I know that my diet has got 60 grams of carb, and then I know that if I take 5 units of insulin, then this food, if I take, results in absolutely matching of my food and my insulin curves. And then 4 hours down the line, my sugar values are going to go ahead and come back to the baseline, as we discussed in last session. So which means that 60 grams of carbs require 5 units of insulin for them to be assimilated in the body. So my insulin carb ratio becomes 12. So because by giving 1 unit of insulin, I can assimilate 12 grams of carbohydrates without any much fluctuations in my baseline blood glucose values. Now this insulin carb ratio varies in different persons, can also vary at different times of the day depending upon what our physical activity is. It also changes as we become older, as we grow. So in anybody, what we can do is we can start with a very basic formula, something called 500 rule. So what we do is we divide 500, number 500 by the total daily dose. So for example, if you're not sure what my total daily dose looks like, then what I should do is that say my total daily dose that I'm currently taking is around 0.1 unit per kg per day. Then that's all right. I can go ahead and start with the same units that I'm taking. But if my baseline units are like, say, I'm taking much more than required. So I'm taking, say, 1.5 units per kg per day right now. What I need to do is perhaps we should take total daily dose as 0.8 units per kg per day. But if somebody is having hypoglycemia, even at 0.8 units per kg per day, but what I mean by 0.8 units per kg per day is that if somebody with type 1 diabetes has 50 kgs of weight, so 0.8 units per kg per day would mean that that person should not require more than 40 units in a day, right? Because 0.8 units per kg, for 50 kgs, we require 40 units. So it should not be more than 40, but say I'm taking 40, but there are still some low sugars which are happening every day. I am experiencing hypoglycemia still in between any time of the day. Then it may be all right to cut the total daily dose by 20-25% and then start building up from there. So now say I was taking, my weight is 50 kgs, but I'm taking say 60 units already, which means I'm taking more than 1 unit per kg per day. So then if I have to restart doing my calculation, so I would start with a total daily dose of say around 50 units or so, or somewhere between 40 to 50 units or so, depending upon I have hypoglycemia or not. So I would start with 500 divided by 50. I would say that, okay, for 10, so that would give me 10, 500 divided by 50 is equal to 10. So then I would say, okay, for my body, perhaps 10 grams of carb need 1 units of insulin to be metabolized. And that's only going to be my starting point. We're going to discuss in the coming sessions. But we need to understand insulin carb ratio. 1 unit of insulin, how many carbs it can assimilate so that my basal blood glucose value stays stable. Now this is called insulin sensitivity factor. So say it has got nothing to do with the food. It has to do with my blood glucose value. Say my blood glucose values are 250 at the moment, and I want to bring them down to 150. Then I should know as to how much insulin should I inject, even if I'm not taking food, but I want to bring my values from 250 to 150. How much insulin should I inject to bring it down? Now that comes from a formula called 1500 rule, right? So different people use from 1500 to 1800, but we need to start off, and we can start off with any of them. That's okay. Few people would say that you can change that formula based upon rapid acting insulin or regular insulin, but any of them are okay. Doesn't make much of a difference. So say my total daily dose, I've decided my total daily dose is 50. Then I divide 1500 divided by 50, which means 30. So if I want to bring my sugars down from 250 to 150, then that's 100 milligrams of carb that 100 milligrams of blood glucose values that need to come down. And I know that my insulin sensitivity factor is 30. So I need to inject 3 units of insulin. So to bring that blood glucose values from 250 to 150. Now it is not that we should, each time that my values is 250, then I have to bring it down to 150 and I take 3 units. I need to understand whether I really need to bring that 250 to 150 or not, at what time it is. Like, for example, if you check your sugars 2 hours after your meal and it comes out to be 250, you have to understand that the insulin that you've taken pre-meal is still working in your body. So maybe taking additional 3 units at that time may eventually cause hypoglycemia, right? So this correction dose or we call it as a correction dose based upon the insulin sensitivity factor that we take, should be taken very, very conservatively. And then we are going to discuss in subsequent slides as to how are we going to and when do we take it. So rule number one is fix your diet, fix your exercise. Once we are starting off with this exercise of fixing our own insulin dose, or as a diabetic educator, you are going to set somebody's dose. So first of all is, we need, initially to start with, we need to keep things simple. Fix a diet schedule, fix it for the diet for the entire day, at least to start with, so that you and the child and the parents of child can understand the entire concept more clearly. So we by and large fix a diet, and we tell them that of course going time, we can change that diet as we learn more and more about how do we adjust our insulin according to the food that we take. So we fix the diet, we fix the exercise. And the most important thing in both of them is the timing. So we need to fix the timing for both diet and exercise. Once we have set diet and exercise, then the next job for us is to set our basal dose first. So the basal dose, as we defined in the last session, is basal dose is a dose of insulin, which even when we are not eating food, if we take a basal dose of insulin, my sugar values should stay stable. It would account for the glucose that is being produced by in a way of gluconeogenesis, and which is being required by our insulin sensitive tissues on the basal level. So some amount of insulin which is required. So how do we set that? So the basic premise is that if I inject insulin today at 6 o'clock and then I don't eat anything, my sugar values should be stable, right? And then another concept that we learned was that once we take food, and if my the insulin that I take pre-meals, depending upon if it is a rapid acting insulin, then it will bring my down values, blood glucose values down to the baseline in 4 hours. In the case of regular insulin, that may be around 5 to 6 hours. So depending upon what insulin we take, we believe that in pre-meal insulin, whatever pre-meal insulin that we take, that's no longer going to work after 4 to 6 hours. So say I'm going to take an example of a rapid acting insulin. So what I want to say is that, say, for example, I took my dinner dose at 8 o'clock. And then I took some X rapid units. And then after 4 hours, I know that my sugar value should touch base. And then I say that, okay, my values are somewhere between 132 or 122 to 180 post-meal, post-dinner, 4 hours post-dinner. So then I assume that if my basal dose is correct, then my sugar value should stay where they are, within plus minus 10% of where they are now. Right? So that's the basic concept. How do I do it practically is, perhaps I take an early dinner, maybe to set my basal dose. What I do is I take my insulin at 6 o'clock. I eat my dinner at 6 o'clock. Then by 10 o'clock, I assume that I've touched the baseline. And then I assume my sugar at 10 p.m. is 130. Now, if my basal dose is adequate, then it should be 130 at 6 o'clock next day, which means even at gap of 7-8 hours, my value should not fluctuate. So how do I do that is, I check my sugars at 10 o'clock. I check my sugars at perhaps 12 o'clock or so before I sleep. And then I check my sugars at 3 o'clock. And then I check my sugars at 6 o'clock in the morning. And then all those 3-4 readings, 10 p.m., then 12 a.m., then 3 a.m., and then 6 a.m. should be within 10% of each other. If they are there, bang on. My dose for basal is correct. If my graph is going up, then of course I need to increase my basal dose. Then if my graph is going down, so say my sugar was 180, and then it has come down to 130, which brings me to the next thing. Basal does not mean that my post-dinner 4 hour at bedtime, if it was 180, it should not come down to 130, which means my basal dose is more. It should stay at 180. I might increase my basal dose, or I might look at my pre-dinner dose to bring that 180 down. But otherwise, it seems that my basal dose is overall correct. It can hold on my basal glucose values to where it is. So we take an early dinner, we check 4 hours afterwards, and then we check it every 2 to 3 hours during entire night. We do it over 2-3 days. They may not be consecutive, they may be separate. But based upon that 2-3-4 days data, then we decide how our basal dose is going to look like. This becomes much more easier if somebody is using CGMS. CGMS means continuous glucose monitoring system. So there are a lot of continuous glucose monitoring systems now come, which check your sugars every 10 to 15 minutes, and then they give you a graph. So then that graph gives me nice graph for the entire night. If my entire night graph is flat, then my basal is okay. If my entire graph is not right, then then I need to either increase or decrease the dose depending upon the values of the basal of the line that or the blood glucose values graph that I get. This is true for glargine insulin. This is true for degludec insulin, right? Because they are given once in the day and then they work for the entire day. Now for glargine and degludec, practically speaking, we do not need to do anything during the daytime, because we assume that if they are enough to hold my blood glucose values in the night, they are going to hold my blood glucose values during the entire day also. And in any case, because we cannot vary their dose, we have to give it once in a day. So the nighttime maintenance of blood glucose values is much more important with those basal insulin than trying to look at what our day values also look like. Now, if we are doing NPH, which we discussed that we have to take twice in a day. So then, first of all, we need to do an overnight test as we did for the glargine and the degludec. But then, because we are taking another basal insulin during the day, so what we need to do is, suppose I took an NPH in the morning. Now, what I need to do is I need to skip my breakfast for that day, and then I keep on testing every 1 to 2 hours, and then I make the same graph line. And then if my NPH dose, my basal dose is correct, then my sugar values, even if I've taken that NPH glucose, my blood glucose values should not go up or high, up or low. They should stay within 10% or so. So that's how I see it. And then I do a similar thing. I do take my breakfast, but then I see whether my basal dose is being correct across the lunchtime or not, and then I adjust my NPH dose accordingly. And same thing happens across the snack also. So if I'm taking snack which is more contains more carbohydrates, so I need to look at the entire day one by one after each meal, that my basal dose is correct all across the day if I'm taking NPH 2 times in the day. For the pump, because in the pump now we were taking glargine and degludec once in a day, we were taking NPH two times in a day. For the pump, we know that we can set the basal dose. In the pump, you have an independence to set the basal dose for multiple times. So like, for example, you can have a separate basal dose which goes from 9 to 1 p.m. and then from 1 p.m. to 6 p.m. is a different, and then 6 p.m. to 10 p.m. is different, and then from 10 p.m. to say morning time is different. Although we expect that you should not have more than 2 to 3 basal rates if you are using your pump adequately. So, but for the pump, we again do the same all across the meal. Across each meal, we go ahead and check how does our basal hold on. All across the meal means that I skip the breakfast and then I see whether my basal dose is holding during that the morning period. Then I skip my lunch and then see my lunch basal glucose values during lunchtime, and then similar thing I repeat during my dinner time. So that's how you set your basal. There is nothing more important than setting your basal, because if you set your basal, now you know that even if you're not going to eat, you do not need any pre-meal insulin. So it allows flexibility of meal time. If I take my lunch at 1 o'clock, if I take my lunch at 2 o'clock or 3 o'clock, it should not matter to me, because I know that my basal glucose is enough, and then whatever my baseline glucose looks like, it is going to stay where it is. Then it makes building pre-meal doses relatively easy. So if you do not have to correct, if your values are not either going up or going lower. So for example, say my basal dose is on the lower side. If my fasting comes 250 every day, then I might have to adjust for that 250. And then I would always be confused as to what my dose for given breakfast should be, because I'm trying to correct that 250 also. So if your basal dose is nicely set, then we know that whatever variation is there is because of the food that we are taking. Whatever the glucose is there in the food is causing that fluctuation. So we need to work on the pre-meal doses then, rather than working on the basal dose then. And then of course, if your basal dose is correct and you are not having much fluctuations, then your risk of hypoglycemia is also going to be lower. Now, once we have set a nice basal dose, then what we are going to do is we are going to set our pre-meal insulin. And then pre-meal insulin, we set one meal at a time. Traditionally, we start with the breakfast, then we start with the lunch, and then we go ahead and work it with the dinner. Now, how do we set? So what are the basic rules for setting or the basic concept of setting our pre-meal or the prandial insulin dose, as we call it? So what we believe is that if we are taking rapid insulin, then at 4 hours after we've taken meal, my blood glucose value should come back to where they were pre-meal. So like, for example, if my pre-meal value was 130, then if my dose of insulin is correct for the given meal, for the given carbohydrate that I'm taking, then 4 hours after that meal, my blood glucose value should again be plus minus 10% of 130 milligrams or so. Now, conventionally, we check sugars not after 4 hours of meal, but we check it 2 hours after meal. Now that's because of practical consideration, because nobody generally eats within 2 hours of the meal. But it is likely that people would eat again and again within 4 hours of their one meal. And then if we eat something in between, so say you took a cup of tea after 2 hours after you, or 3 hours after your meal, then of course the sugar or the blood glucose values that would be fluctuated by that cup of tea would be reflected in the 4-hour value that you're going to check. So conventionally, 2-hour values should be 40 to 60 milligram per deciliter of what your baseline was. So for example, if my pre-meal blood glucose values were 130, then 2 hours after meal, my value should be somewhere between 170 or around 180 or so. So that's the limit. And if I'm there 2 hours, 40 to 60 plus my pre-meal values, or at the same values 4 hours after as I was pre-meals, then I would say that my pre-meal dose is adequate. Now we start off with if my diet is fixed and I do not really want to do any carbohydrate exchange or any carb counting going forward. So say my diet is fixed every day. So then what I do is, thing is simple, that I know what my total daily dose is. So my total daily dose, say I was 50. And then we decided that my total pre-meal dose in an entire day is going to be 25, half of total daily dose, half goes as basal and then half goes as pre-meal insulin. So then I know that dose at each meal is, as a starting point, can be 8 units. Then I take my fixed breakfast, I take 8 units, and then I see if my blood glucose values at end of 4 hours are higher or at 2 hours are higher than what I expect them to be, I gradually increase the dose by 10% after 2 to 3 days. But if my values are lower or I'm going on the lower side than what I expect them to be, then I decrease my dose by 10% or so, and then I see. Ideally, if my values are going lower, I can even reduce it by 20% or 30%, depending upon how low my values are going. So we need to lower our dose in larger steps as compared to when we try to increase our dose. So that's how we go ahead and do. So I took breakfast today, and then my breakfast was fixed. I took 8 units, but 4 hours after I checked my sugars, they had risen by 20-25% of what they were pre-breakfast. Then I am going to take not 8 units, but maybe 9 units tomorrow. And then, and we do not increase it every day. First of all, whatever my values are, I'm going to confirm them with the same dose tomorrow, and then maybe for 1 more days. And then if 3 days pattern tells me that my blood glucose values at end of 4 hours are on the higher side, then we go ahead and increase the dose by 1 unit. And that's how we keep on increasing the dose and setting. Once they become stable, all right, then that's what the dose is going to look like for you. Now, if somebody really want to do carb counting or insulin carb ratio, now the disadvantage with the previous approach is that as long as your breakfast is fixed, you're taking same thing at breakfast every day, then your sugar values are going to be stable. While on the other hand, if you are taking different breakfast every day, then of course same dose of insulin is not going to work. Because if you've taken same dose of insulin, but if you have changed the carbohydrates that they're in your food, then your sugar values are going to go fluctuate. So to counter them, what we do is we introduce a concept of called insulin carb ratio, as we discussed in previously. Now, if I know that my breakfast has got 60 grams of carb in it, right, and I need to take 8 units of insulin before each meal, then I know that my insulin carb ratio is 8. On the other hand, if I believe that, my insulin carb ratio, my blood glucose values are higher on the 4 or after 4 hours or so, then I need to lower my insulin carb ratio, because then my insulin is assimilating lower amount of carbs than it should. So that's how it is. So I keep on adjusting, as we did with the absolute dose, depending upon the carbohydrates we take our units. Now, for example, I want to take 40 grams of carb tomorrow. Then what I need to do is I am going to take insulin dose, not the same that is fixed for every day, but I'm going to take for whatever is there according to my carbohydrate. So if my insulin carb ratio is 8, then I'm going to take 5 units of carb. I'm not going to take 8 units of carbs for it any longer. And then I adjust it for breakfast. Once it is adjusted for breakfast, I adjust it for lunch, and then I adjust it for dinner. Now, the concept of correction dose we have already considered. So say my pre-meal values are more than where they should be. So ideally my pre-meal target should stand somewhere between 90 to 130 or so. But if they are more than where they should be, I know that I need to take insulin for the carbs that I'm taking, but I also need to take some amount of insulin so that my blood glucose values, which are on the higher side at the moment, should come down. Just to give you an example, so say my pre-meal blood glucose was 130 and my mealtime dose is 6 units. I go ahead and take that 6 units. But if my pre-meal pre-meal blood glucose values is 230 before same meal, then of course those 6 units of insulin are going to bring it down to 230 only, because it is going to give me same basal levels of insulin as they were previously before pre-meal. So what I need to do is, and then if I know my correction dose, which we calculated, if my total dose is 50 units, so then my correction dose is say 30. For 30, I need for 30 grams per deciliter glucose to come down, I need 1 unit of insulin. So I need 3 units of insulin extra. So if my blood glucose values pre-meal was 230, then I would be needing total of 9 units, 6 for the meal and 3 as a correction unit, right? So that's how you calculate your dose for each meal. Do not forget to cover your snacks. If you cover snacks has got larger carbohydrate content, then they should be covered by insulin. So for example, my insulin carb ratio is 12. So which means that the 12 grams of carb can be assimilated by 1 units of insulin. So anything which has got 12 gram carbs or more, if I eat that thing as snack, then I need to inject that 1 unit of insulin or more than that, what is required, so that my blood glucose values goes to back down to the baseline, so that at the basal level they are maintained. Do the rule apply at all phases of type 1 diabetes? No, they do not apply at diagnosis, at honeymoon period. At diagnosis, we may require much higher doses than 0.8 units per kg per day. In honeymoon period, we may require lower. Honeymoon period, because there is some amount of insulin that is still secreted by our body from inside. So then we may require a lower units of insulin than otherwise. After honeymoon period is over, then of course everybody requires same units as we discussed. As a rule, we treat hypoglycemia first, because if you do not treat hypoglycemia first, then hyperglycemia can never be treated, for 2 things. First of all, hypoglycemia, we need to understand it. Hypoglycemia is as dangerous as hyperglycemia is. Specifically in children less than 6 to 8 years of age, each time that we have lower glucose, it can affect their cognitive function in the long run. Second thing is that as our glucose goes low, body starts working more. So what body does, it starts producing more glucagon. And then your liver and kidney and everything starts producing more glucose from inside. So even without eating, if you've got an hypoglycemia, there is a chance that your sugars might go up. So this is something called an high glycemic roller coaster. Your sugar values go low and then your sugar values go high, and then go low and then go high. So we need to remove hypoglycemias first, and then we need to go ahead and go for treating hyperglycemias. Now, what we need to do is we need to treat patterns. We never go after individual values. If I just show you these values, if you look at on one day, right? So what it shows is on day one, fasting is 90, pre-lunch is 110, and pre-dinner is 156. Now we see that the fasting and pre-lunch are pretty much almost within 10% or within the range that we want them to be, but before dinner values is slightly on the higher side. But what we see next day is that our values are 180, and then 200, and then 244. So what you see at is that the fasting and before lunch are still within almost 10% of each other. Before dinner values is still a little bit higher than what the pre-lunch values was. But the difference is that where we are starting with. In all probability, what is happening in this case is the child or the parents are deciding to vary their insulin dose at the dinner time. Now that may be pre-dinner dose, because they might think that, okay, I've got 244, and then without any calculation, they are increasing the dose, which is bringing down your fasting values low to the 140. But on the other days when your pre-dinner values are 156, they are taking lower dose, thinking that, oh, my values are lower and then I need to take lower dose. Or maybe they are taking same dinner dose and they are reducing the basal dose on the value it is low. So the day the before dinner is low, the next day values goes high, while there is happening in the vice versa. So you need to look at the pattern. Let's stay at same doses and then try and see, and then work on that pattern. Don't go and shoot off the hip for each blood glucose values that is there. So that was the basic concept. Just to summarize, we need to fix the diet, we need to fix the physical activity, we need to know what our total daily dose should look like. We should set the basal dose first, as we discussed. We need then go ahead and decide on the mealtime dose. Do not forget the snacks if they contain adequate amount of carbohydrates, and then you need to treat your hyperglycemia first. Okay. So in the second part of the same talk, we need to talk about practical issues of insulin. Insulin is given through two basic devices. Ones are the pens and the other are the needles. So needles are more commonly used. But the thing that we need to take care while we are asking people to take it with needle is that there are two different kinds of needle. One needle is for 40 IU per ml, another needle is for 100 IU per ml. What I mean by them is that although the insulin is same, but they come in different concentrations. So if we take a larger concentration insulin with a smaller concentration needle, which is meant to be used for the lesser concentration of insulin, then the dose of insulin that we would be taking would be much more than it is required. And similarly, if the opposite happens, so that we need to ensure that the needle that we are taking is matching with the preparation of insulin that we are taking. Pen fills are the another devices. So there are pens which are more commonly used nowadays, specifically in the urban setting, and then all of them come in a uniform preparation, but they are company specific. While needles are universal, the pens are company specific. For one company, insulin of one company, we need to use pen of same company. So that are the two basic differences that we need to keep in mind while we are using pens versus needles. So 40 IU and 100 IU. So we need to see as to where they are. Where do we inject? We can inject theoretically on the arms, on the abdomen, on the buttocks, and on the thigh area. But we generally prefer abdomen and the thigh, because if somebody is injecting themselves, self-injecting, then these are the two sites where it is easy to guess and hold. If I have to inject myself and I'm trying to inject in the arms, so my arm can shake and I do not know exactly where my needle is going. Similarly, thing can be true for the buttocks. So generally the thigh and the abdomen is where we inject. We need to remember that insulin sites need to be rotated. which means that I should not ideally be injecting insulin within 1 finger breadth of the insulin site that I injected today over next 2 weeks or so. So I need to use my entire abdomen apart from the area around my navel. So I leave 2 fingers around my navel where I do not inject. But apart from that, I use my entire abdomen and I use it systematically. I go from one side to another in one plane. And then once I'm reached the other side, then I go maybe come 1 finger down and then I go to the other side. And then there are different rotation patterns or methods that we can follow. But the basic principle stays same, that I tend to avoid injecting at the same time for next 2 weeks where I've injected today. And another thing that we need to remember is insulin injected at same site means abdomen, and same units of injecting at thigh may not work similarly. Insulin works little more efficiently when it is injecting in the abdomen, little less efficiently in the thigh. But that does not mean that we cannot use thighs or we should use abdomen only. We need to know what dose given at abdomen is going to work for my food or as a basal insulin, and similarly for thigh. So how do we practically do is that if we have to take basal dose on the thigh, then we take that basal dose on the thigh every day. We don't use it on the abdomen. Similarly, if before breakfast we decide to inject on the abdomen, then we inject on the abdomen every day before breakfast. Similarly, we can decide which site to inject at before each meal, and then we stay put at that site for that particular site. So this is exactly showing the same thing, that when same insulin injected at different sites, either abdomen, deltoid is your arms, and femoral, which means your thigh areas. So then they start working at different time, and then they work longer or shorter depending upon which site are we working for. Generally speaking, now most of the syringes, the needles, the syringes, and the pens are around 4 mm or so, which is adequate, because we need to inject in the subcutaneous tissue, which is just beneath our skin. Our skin is around 2 to 3 mm thick, for both for fat people and both for thin people. So ideally, if our needle has got 4 mm length, then we can inject our pen or the syringe at right angle to the surface wherever we are injecting, and that should go into the subcutaneous tissue despite whatever your level of fatness is. For very small children, we may need to raise some skin fold, because we want it to go beneath the skin. We do not want to go the insulin to be going into the muscles, right? So we raise the skin fold and then we inject into that. We need to store insulin at a temperature which is between 2 degrees to 30 degrees. At temperatures between 8 to 30 degrees or so, your insulin is stable only for 28 days. When insulin is stored between 2 to 8 degrees, then it would be valid or okay to use it till that time of expiry date. But for insulin that we are using, even if we keep it at less than 30 degrees or so, then it can work for almost 28 days or so. When we are storing our insulin in the refrigerator, it should be stored in the door part of refrigerator, never in the freezer. And then we need to bring this insulin out at least 15 to 20 minutes before we inject ourselves, if we are storing it in the refrigerator. In Indian household, in summer specifically, we need to store our insulin very, very carefully, because even in the local room, in our room where there is no fan or AC or anything like that, then temperature might cross 30 degrees and insulin can go waste after that. So these are the manufacturer. What they tell us is that if we have opened up insulin vial or insulin pen, and then if we are keeping it at room temperature, which means between 8 degree to 30 degrees, then it would only last for 28 days, not more than that. Traveling with insulin is generally an issue, but we need to use an ice pack. There are also specific ice packs comes with which a lot of insulin companies provide free of charge. We can also sometimes use a simple, we take a a bottle, a thermos, as we call it. We put our insulin into a plastic a zip box or some plastic box, and then we uh, 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 wrap some elastic bandage around it, and then we maybe drop that insulin to that thermos bottle along with ice and everything, and then it can stay safe for hours and hours together. We do not leave it in a closed vehicle, because in closed vehicle in India specifically, your temperature can go even up to 48 degrees, 58 degrees, and things like that. People might need certificate for air travel to take their insulin along, but nobody can stop anybody from taking insulin in the air travel. While you are traveling by air, you need to keep your insulin in the hand baggage, never in the check-in baggage ever. Because in the check-in baggage, you do not know what kind of a temperature is being maintained there. So while if in the hand baggage, because we are sitting in the passenger cabin, so their temperature is generally maintained. So we need to keep our insulin in the ice packs and everything, and then we take it as a hand baggage during the air travel. We need to procure insulin from any channel we can do, but we need to, the channel should be reliable enough that we are sure that the cold chain is maintained. Because most of the time, when insulin is being given from too good to be true prices that come from scrupulous sources, and then those sources are generally not very diligent in maintaining that cold chain. So if your cold chain is broken even for a day or two, you do not know what kind of an efficacy or efficiency of that insulin would have. Ideally, we should be disposing needles very carefully, because these needles are invasive. If we put that in the municipal waste, then they can be hazardous for other people. We should use cardboard hard boxes, where puncture-proof boxes, where we put these needles in, and then we go ahead and discard them to our healthcare providers in a proper manner. Taking insulin can be a painful experience, but there are a few things that we can do to avoid that pain during that painful injection. Is that injection should not be injecting cold. We need to take at least 15 to 20 minutes out of refrigerator before we inject. If we are using spirit to clean, which again is if my abdomen is clean, and then there is nothing which is I have not worked in the dirt, and I wash every day, and then I take bath every day, then there is no need for me to clean. I can just uncover my abdomen, and then I can just inject. But if I choose to clean, if I cleaning it by spirit, I should allow that spirit to clean, because the spirit, that if that is wet, is going to can cause pain. Then using needle too many times. Ideally, the needle of insulin that we use is a one-time use. People use it practically more than one time in the entire world. Medically, we cannot condone that status. We generally say that one needle should be used for one time. However, if we use it for more times, then the chances of pain, as more needle is being used more and more frequently, that increases. And then few people use those shaky hands. So those hands should not be shaky. So your insulin needle should go into your subcutaneous tissue in one clean stab, and then generally it doesn't pain. So those are the practical issues. And then I think everybody knows that we last time is that we dial the insulin as much as dose we want, or we take that insulin in the syringe as much as we want. We hold our skin with one hand stable, and then we inject at 90 degrees. And then once we have injected at the 90 degrees, we just count till 6 in our mind. 1, 2, 3, 4, 5, 6, and then we take that out. So that was all. We would be providing you more detailed written module for all these practical purposes of insulin, as to how it should be used in the clinical practice. So you should, whatever is left should be covered in those modules, or we can go ahead and ask that in our question answer session.